Hi, this is Mikkel Benoit.
And I'm Anna Sayre.
Today we will discuss our systematic review regarding intraoperative NMDA antagonist administration versus opioid therapy in reducing postoperative pain in opioid-dependent patients.
The modern day opioid epidemic poses new barriers for healthcare, patient quality, and community growth. Anesthesia providers are likely to encounter opioid-dependent patients. The Centers for Disease Control and Prevention estimated that the United States suffered $78.5 billion in debt due to prescription opioid abuse. Addiction to opioid occurs in approximately 10% of patients prescribed opioids for chronic pain. These patients are susceptible to hyperalgesia, inadequate pain control, and poor patient outcomes due to a combination of acute and chronic pain with developed tolerance to opioids. Acute pain exists as a biological response to protect the body from harm. Chronic pain outlasts the protective state and leads to physical and psychological derangement. Various methods of opioid-free, opioid-sparing, and multimodal analgesic protocols have been studied without establishing a definitive treatment. One option that warrants further investigation is the incorporation of intraoperative NMDA antagonists. The NMDA receptor exists mainly in the central nervous system, is activated by glutamate and glycine, and in turn activates neuronal pathways that lead to the development of chronic pain and opioid tolerance. Disrupting this pain pathway with NMDA antagonists offers an opportunity to combat postoperative pain in the opioid-dependent population.
The theory of unpleasant symptoms proposes a relationship between physiological, psychological, and/or situational factors that lead to the development of unpleasant symptoms and alteration in performance. Patients with opioid dependence have these physiological and psychological factors of opioid tolerance and dependence. They are then put into the situation of undergoing surgery, which presents a state of distress. The unpleasant symptoms would be manifested as postoperative pain. Uncontrolled postoperative pain leads to physiological changes that decrease healing, the inability to perform activities of daily life, and patients' dissatisfaction with surgery. The pharmacodynamic properties of various NMDA antagonists and pure opioid agonists are physiological factors that influence the development or absence of unpleasant symptoms.
Our problem statement is to evaluate research that incorporates intraoperative NMDA antagonists versus administration of pure opioid therapy in reducing postoperative pain in the opioid-dependent patient population.
Study populations must consist of adult surgical patients with a prior history of opioid dependence. Studies without focus on this patient population were removed due to proposed alterations in the pain pathway. Interventions include intraoperative administration of any NMDA antagonist, ketamine, methadone, magnesium, to decrease postoperative pain. Studies were excluded if NMDA antagonists were not dosed intraoperatively. Comparisons include intraoperative administration of a pure opioid, such as morphine or fentanyl, current multimodal non-opioid analgesics like lidocaine, and/or traditional general anesthesia. Outcome measures include quantitative postoperative opioid dosages, patient-reported pain scores, and additional patient satisfaction measurements. A study was excluded if postoperative opioid dosages or pain scores were not recorded. Case studies, clinical trials, retrospective studies, and evidence-based practice were included in this review. Studies were not excluded based solely on design.
Multiple databases were searched using words and phrases related to the population, intervention, comparison, and outcome of our research question. You can see these terms within our PICO search strategy chart.
951 articles were related to our topic. These were then narrowed down to 8 articles after removing duplicates and excluding studies that did not align with our PICO question. 2 articles were excluded for lack of a control group and excessive opioid administration. This gave 1 case study and 5 randomized control studies. There were 485 adult surgical patients within the 6 studies. These participants were an ASA 1 to 3 and had a history of opioid dependence. Two themes were discovered throughout the chosen research studies.
It was first noticed that incorporating intraoperative NMDA antagonists reduced postoperative pain in patients with a history of opioid dependence. Gottschalk et al. 2011 studied intraoperative methadone bolus versus sufentanil bolus in continuous infusion in complex spine surgery. Methadone patients had significantly reduced postoperative pain and opioid requirements 48 to 72 hours after surgery. Nielsen et al. 2017 compared intraoperative low-dose IV ketamine bolus and infusion with a placebo bolus and infusion of normal saline. The ketamine recipients required less postoperative morphine than the placebo group. Nielsen et al. Did a one-year follow-up in 2018, which found long-term pain and opioid consumption was also reduced in the ketamine group versus the placebo. Quiambo 2016 performed a case study using intraoperative multimodal therapeutic regimen containing gabapentin, methadone, ketamine, dexamethasone, methocarbamol, and acetaminophen. The study showed reduced postoperative pain in a patient with chronic opioid use. Samadini et al. 2018 compared intraoperative boluses and infusions of 2% lidocaine, ketamine, and normal saline placebo. The study determined that postoperative pain, sedation, analgesic requirements, and patient satisfaction were improved in the ketamine group when compared to the placebo group. Overall, however, outcomes were superior within the lidocaine group. The 5 articles in theme 1 conclude intraoperative NMDA antagonists improve postoperative pain scores, opioid requirements, and activity levels in those with opioid dependence. Samadini et al. 2018 shows ketamine improved postoperative pain and reduced opioid consumption compared to placebo, but lidocaine provides even more improvements. Due to the consistency of their results, in 4 of the 5 studies having been well-designed RCTs with high levels of evidence, the U.S. Preventative Services Task Force states future data is unlikely to conflict with their conclusion. Incorporating NMDA antagonists for postoperative pain in the opioid dependent is worthy of recommendation.
The second theme observed was incorporating intraoperative NMDA antagonists did not reduce postoperative pain in the opioid dependent patient. Subramaniam et al. 2011 studied intraoperative ketamine bolus and 24-hour infusion versus a placebo bolus and infusion of normal saline. Both groups had similar postoperative pain, postoperative hydromorphone requirements, and incidences of adverse effects. Subramaniam 2011 found no improvements in postoperative pain scores or opioid consumption when comparing intraoperative ketamine to placebo. This evidence does not support a practice change placing NMDA antagonists as the superior intervention in reducing postoperative pain in chronic opioid users. The USPTF would not support placing this conclusion into practice because of the small sample size and disagreement with multiple studies of similar design and evidence level.
Ultimately, NMDA antagonists either improve or do not affect postoperative pain. They definitely do not increase it. All studies suggest a trend towards an opioid-sparing anesthetic to reduce postoperative pain in the opioid-dependent patient population. The studies disagree with which treatment is superior, but the majority of evidence supports NMDA antagonist implementation. Trials comparing individual doses and multimodal combinations of lidocaine, ketamine, methadone, and a pure opioid are needed to block the many pain pathways and improve postoperative pain outcomes in this patient population.
Limitations to this review were small sample sizes, low response rate, and inconsistency of blinding, interventions, and surgical procedures. One main issue is that multimodal analgesia blurs the direct cause and effect relationships of NMDA antagonists on postoperative outcomes. Strengths of this review include study design, similar recorded patient demographics among studies, the use of validated tools, and varying country of origin. Blinding of providers was challenging due to the issue of patient safety and/or study design.
Despite there being more evidence in support of NMDA antagonists, there were still inconsistencies between the studies. However, the evidence does support a practice change towards a more opioid-sparing and multimodal anesthetic than a pure opioid or pure NMDA antagonist anesthetic. The best perioperative analgesic plan for the opioid-dependent patient cannot be clearly determined from this systematic review. In order to attack pain from various avenues, multimodal pain pathways must be blocked. Using this theme of thinking, one must develop a multimodal protocol involving known receptors that contribute to pain, such as opioid, NMDA, AMPA, and GABA. If the intention is to block all pain pathways, it is unfair to exclude opioids from the multimodal protocol. Without sufficient evidence to support an equally efficient alternative in blocking the opioid receptor, it may be best to approach opioids in a sparing rather than exclusionary technique.
Trials comparing lidocaine, ketamine, methadone, and a pure opioid with a larger sample size should be conducted. Standard general anesthetic, but treat signs of physiologic pain with non-opioid analgesics first. If no improvement in pain, set doses of opioids should be administered. Weight-based doses should remain consistent among each intervention and participant. Pain outcomes should be measured throughout hospital stay and 6 months after surgery using VAS, opioid requirements, and time of first opioid administration. Research is necessary to prevent further escalation of the opioid epidemic. We hope you enjoyed our presentation and have learned the importance of further research to determine if NMDA antagonists are the future of postoperative pain reduction in the opioid-dependent patient population. Thank you.
Thank you.